Hey, good afternoon, everyone, and happy Monday. I hope you all enjoyed your weekend. We are tuning in here for our Baptist Health Ask an Expert Stroke Awareness Series. So it is May, we are observing stroke awareness, and we have our third part of our series today with the wonderful Kristie Sauer. So I'm excited to have her here. So Kristie, really, looking forward to our conversation today. And I was hoping that you could tell us a little bit about yourself and what you do at Baptist.
Well, thank you for having me today. So I'm Kristie. I'm one of the nurse practitioners. I actually work for Lyerly Neurosurgery in the neurocritical care. So I've been a part of the program pretty much since its inception in 2014. So this is actually what drew me to the program, is taking care of this patient population, especially strokes and subarachnoid hemorrhages. So yeah, I've really enjoyed the last few years, and I'm really excited to be able to kind of share more information with our community today.
Yeah, absolutely. And we're taking something a little bit different today, right? We're going to be talking about aneurysms, and then also what I'm hoping that we could do, or you could do for us, is kind of walk through what a patient could expect when they come to the hospital. But before we get into that second part, I was hoping you could review with us what are aneurysms, and then also how are they related to strokes?
Okay. So an aneurysm is going to be a little outpouching of a vessel, an artery in the brain. So think of the vessels in your brain like pipes, a pipe system, and a little balloon develops on the end. And then as that pressure builds, that balloon can get larger and larger, and eventually it can rupture. Not always, but it can rupture at times. So when we talk about stroke, there's two different types of stroke. So there's an ischemic stroke, which would be where you have a vessel that's been blocked off and you lose blood supply, and that causes the ischemia. So an area of the brain, essentially dies, and that's where you get an ischemic stroke. You can also have a hemorrhagic stroke. There are many different reasons that you can have bleeding on the brain. Sometimes it can be a small vessel related to like uncontrolled hypertension, the pressure's too high, and you have some bleeding on the brain. And you can also have what's called a subarachnoid hemorrhage, which is where an aneurysm ruptures and you get blood within the kind of the fluid-filled areas in the brain, the subarachnoid space. And it's a very different approach in how we treat both of these patients. So about 5 to 10% of all strokes are actually considered a subarachnoid hemorrhage.
Oh,
Yeah.
okay. And then, wow, okay, I didn't realize that. So, and then like with aneurysms, could you tell us kind of the difference between an aneurysm versus a stroke?
Well, the stroke is essentially the bleeding on the brain.
Oh, okay.
So an aneurysm is really just what caused the stroke.
Oh, I see.
So
Okay.
when we look through like our different stroke workups, you can have, bleeding, you can have hypertension related, you can have a subarachnoid hemorrhage, you can have some people have amyloid, and that causes the bleeding on the brain. So the stroke is essentially, okay, you've had bleeding on the brain. The aneurysm is just the cause of the stroke.
I
And
see.
about 4% of the population have an aneurysm and are completely unaware of it.
Gotcha. Okay. So, are the symptoms similar between an aneurysm and a stroke? And can you catch them, I guess, beforehand?
Yeah, so like I said, 4% of people have an aneurysm and are completely unaware of it. So obviously it can be asymptomatic. The people who have symptoms with an actual aneurysm, and I'm talking about an aneurysm without rupture, is based on the location and the size of an aneurysm. So aneurysms, just to back up a minute, tend to form where there's bifurcation of the vessels, kind of where they meet. So that's a higher pressure point. And then in certain areas like communicating, like your anterior communicating artery or posterior communicating artery, that's where you will tend to develop them. Now, depending on the location is where some people can get symptoms that cause them to come in before it ruptures. So an example of that would be like a posterior communicating artery. Some patients will have pressure on their cranial nerves, and they'll actually have problems with their eye movements. They may have pupillary changes, or even like a subtle drooping of the eye, which can be like a third nerve palsy, partial ptosis type thing is what we call it. So those would be like symptoms that someone has and they just happen to catch an aneurysm based on that, or visual changes. Sometimes an ophthalmologist will say, hey, something's not right, go get a scan and look at the vessels of your head and your neck, and then they can see it. Now, when we talk about a ruptured aneurysm, that is very distinct. So, when people come with a stroke, and I know you had that series with Margie a few weeks ago, you talk about, all this sudden onset weakness on one side and numbness and facial droop and all that. You can have symptoms like that based on where the bleeding is in the brain, where you have, numbness or weakness on one side. But the most distinct symptom of a subarachnoid hemorrhage is going to be a sudden severe headache. So people will ask, well, how do I know, like, if I really have that and I need to go to the emergency room, or if this is just a migraine? So a migraine is something where you get a headache and then it gets worse and it gets worse and worse and worse. You're like, oh my gosh, my head is killing me. Yeah. Whereas with a ruptured aneurysm, it's going to be like, bam, sudden onset headache. And from the beginning, it will be like the worst headache of your life. And that's what people describe it as. They will describe it as a thunderclap headache that happened all of a sudden and the worst headache of their life. Some people will complain that there's like a pop and then all of a sudden my head hurt really bad. Very interesting as to the location of the aneurysm. They'll be like, it hurt really bad back here. And you're like, yeah, I know. That's where it ruptured. Oh, sorry. So anyway, it's just my phone talking to me. So that's going to be the more distinct. And then some people, in addition to the headache, will have like nausea, vomiting, neck stiffness. Some people will kind of get confused, and you can have a seizure when the aneurysm ruptures, and then also a sudden loss of consciousness. So I'm sure some people have heard at times where it's, I was fine, and then they just passed out, and that's sometimes the aneurysm is ruptured. Yeah. Obviously, medical emergency.
Definitely. Is there any like common causes as to why like a rupture or an aneurysm will just rupture, or is it just kind of random if you have one?
So there are things that increase your risk of having an aneurysm rupture, but no one could definitively say, oh, it's going to rupture. And I can say in my experience, we've taken care of people with like a tiny blister of an aneurysm versus like a giant aneurysm as well that had ruptured. So just to talk about some risk factors that you could do to, prevent rupture yourself. So one thing is smoking cessation. So people that smoke have a higher risk of an aneurysm rupturing. It's one of the first things we tell people that come in with an aneurysm. If you smoke, you have to quit. One of the studies I was looking at just in preparing for this today showed that there's actually a 2.4% decrease in your risk of having or in your risk of aneurysm rupture if you quit smoking. So that alone is going to help. And you'll as we talk about this, you'll see that most of these risk factors are things that we should do anyways to be healthy, and especially your heart health as well. Another thing would be blood pressure control, right? Hypertension is going to be a reason for you to have a rupture. And one of the studies showed that decreasing your blood pressure by 1 millimeter of mercury, so that top number down just by 1, decreases your risk by 7.1%, which is actually pretty impressive.
That's significant.
Blood pressure control is very important. Controlling your diabetes if you're diabetic. Let's see what else. Obviously, no drug use. Cocaine is a huge risk factor. You have very significant spikes in blood pressures with cocaine use. Heavy alcohol use. Limiting things like atherosclerosis. So still heart healthy diet like we recommend for everybody. All these things are going to help you. One risk factor that's not necessarily preventable, but head injury. Sometimes we see some aneurysms associated with a head injury. Other risk factors that are really beyond your control would be a family history of having an aneurysm. So we actually know that this runs in families. So we already know you have a 4% risk, right, just based in the general population. If you have one family member with an aneurysm, your risk goes up to 6%. If you
Oh,
have
wow.
2 family members, that goes up to 8%. So we already know this, and we actually recommend that if you have a relative, more specifically like a first degree relative, like brother, sister, mom, father, or even like, grandmother, aunts, uncles type thing, um,
Hmm.
that you have preventative screening. So even when we see patients in the hospital or even the clinic that have aneurysms, we will ask them if it runs in the family. And if it does, then we recommend that those family members undergo preventative screening with an MRA. So you would actually talk to your primary care provider about that. And based on your family history, usually it's approved by insurance to get an MRA. And that's just an MRI of the brain that focuses on the vessels and can actually show us ahead of time that maybe you have an aneurysm.
Yeah. Wow. That's
Other
good to
things,
know.
yeah, other things would be like polycystic kidney disease. I know
Hmm.
there's a lot of risk factors. Connective tissue disorders like Ehlers-Danlos, which just messes with the integrity of the vessels. And one thing that's particularly more common in women is fibromuscular dysplasia. So it's an incidental finding that we find on vascular imaging, but it looks like a string of pearls on the vessels. And so you have a risk of having an aneurysm with that. Just being a woman puts you at higher risk, and
Hmm.
age is 40 to 60.
Yeah, so kind of a mix of those things that we can modify versus,
Something that you
it's
can.
important to know that family history too. Um,
Yes.
yeah, absolutely. Well, before I know I wanted to talk to you a little bit about treatments and things like that
Yeah.
for aneurysms, but we do have a question from
Yeah,
Robert.
definitely.
So he said, "Hey, hello, of course." He's curious about what is FAST, that acronym FAST, and why is it important to get the patient to an emergency room as soon as possible?
So FAST kind of goes back to our stroke thing.
Hmm.
So the acronym FAST, so F is for face. So you want to look at somebody's face, see if they have weakness on one side. Um, Now I'm like not even thinking about this fast. So A is your arms. So you're gonna have them put their arms out, see if they have a drift. Um, S is gonna be their see, now I'm not even thinking about it. The is that their stance? If they're swaying or something. Now I can't even remember. And then timing is when the onset happens of your
Yeah.
stroke. I see patients in the ER, so I'm seeing them emergent. They come in. So the importance of that acronym is for people to recognize the stroke symptoms and bring them into the ER right away. We have a very limited time frame of when we can treat these patients, and so that's going to be the most important thing. I want to know when it happened and what symptoms they had. And then we know from then if we can treat them with things like alteplase or if they are candidates for like endovascular therapy and such. So different than the aneurysm as far as the aneurysm rupture, but still the same concept is it's a stroke and you want to recognize the symptoms and bring them in right away.
Yeah, absolutely. And especially with that T, which is time, like you said. I think when I was speaking with Wendy last week, she said knowing, and Marjorie, knowing when was the onset of those symptoms, like you said, is really important for just treatments and things like that when you get to the hospital, like you said.
And just to point out for some people out there, is it's not even like sometimes a patient will be like, okay, well, this happened at 3. The most important thing we really want to know, and I think where this kind of gets misconstrued with time, is when was the patient last completely normal? There's a
Oh, okay.
difference between you telling me, you know what, I noticed at 3 o'clock in the afternoon that I looked in the mirror and my face was drooping. That doesn't mean that's when it started. That means
Gotcha.
that you noticed it. And same thing with a family member. Well,
Mhm.
I was talking to them at 3 o'clock and their speech was really slurry or they were swaying or, you know what I mean?
Mhm.
And if that's just when you noticed it, it doesn't mean it's the last time that you saw them normal. So that
Gotcha.
is a very important key factor that we miss
Mhm.
sometimes to bring people in. FAST acronym is used for our rescue personnel. They want the information fast and to give it to
Mhm.
us. But those are the more deep questions that we're going to ask when someone comes into the ER, because that is what matters the absolute most.
Good to know. Yeah, great. Yeah, that's excellent of just kind of differentiating of when were they last normal versus when did you notice the symptoms? Got
And
it.
I just remembered the S, it was just the most ridiculous thing is smile. Have the patient
Smile. Okay. Your smile.
Oh,
There we
it's so
go.
terrible. I do this every day, but
Yes.
I'm just doing a full stroke scale on people, but
Yeah. Absolutely.
yeah.
Awesome. Well, getting back to our conversation a little
Yeah.
bit more about aneurysms. So you talked about risk factors and things like that. But what are some of the current treatments? And I think, the prevention strategies, I was going to ask about that too, but you sort of touched upon that. But could we go over sort of treatments, like when you see somebody with an aneurysm?
Yeah. So treatments, I'll just have you bring up the image that
Yeah.
um,
Ooh,
that I
hold on
sent
one
you
second.
over.
There we go.
So this to me was the best picture to kind of depict what we do to treat aneurysms. So there's two different ways that we treat them. One is endovascularly, which is from the inside basically, and the other would be like an open crani, where we actually have to open the skull and go in and fix the aneurysm. So an open repair would be what you see in B, and that is a clipping on the aneurysm. So basically they will go in surgically from the outside, find the aneurysm and put a clip on it. Obviously, that's like our most invasive way of treating aneurysms. Some aneurysms, because of their size or location, have to be treated this way. But we do try to do endovascularly if we can. So endovascularly means that they will actually go in through the groin. So similar to a heart catheterization, they'll numb up the groin, take you to the angio suite, and put a catheter in there. They will actually thread the catheter up into your neck, and you'll be under fluoroscopy on the table. And as they inject dye, they can visualize all of the vessels in your head and your neck and then find the aneurysm. And once they find it, they can guide their catheter to the location of the aneurysm to treat it. Now, treating it can be different ways. So A actually just shows coils placed in the aneurysm. So they'll actually go through and place one coil in at a time until they've occluded the aneurysm and essentially secured it, and it clots off. And that's how we secure the aneurysm, what we call it, secured. C is where they'll put, it's called a stent-assisted coiling. So they'll actually put a stent in, similar to like stents in the heart and such, but these are specific for the brain. And these stents have an open mesh enough to where they can actually feed coils in through there to occlude the aneurysm. And then the last one, D, is what's called a flow diverter. So it does essentially, as its name, it diverts the flow away from the aneurysm. It's kind of like putting a pipe on there so that it blocks off the aneurysm and it cannot get any more blood supply. There's a few more devices we have that I don't have pictured. Like one of them is a web device that they'll actually deploy into the aneurysm. It's basically an already pre-made mesh that goes in there and occludes the aneurysm. But those are the typical ways that we treat them.
Very interesting.
Yeah.
And so with prevention strategies, I mean, you talked about kind of those risk, eliminating the risk factors, health habits, things like that. Is there anything else that you wanted to include from your list that you talked before?
I mean, really, I think the most important thing I could stress to people is the family history and talking to your family members about it. Sometimes I'll have patients where we'll ask them about their family history and they're not really aware of what happened, but like I had an aunt that died suddenly, or a parent maybe that died at a really young age. That's such an important risk factor because based on that alone, and not to mention other things like knowing that you have a connective tissue disorder or this polycystic kidney disease, you can be screened, and by being screened you could get the aneurysm treated before it ruptures. Because as we go into discussing what it is to be in the hospital treated for an aneurysm rupture, if you could prevent that at all, I mean, you would certainly want to.
Yeah, no, absolutely. Absolutely. Yeah. So if you could just walk us through, I guess, what a patient should expect when they do get to the hospital. And even, I don't know if there's anything in particular from when a patient, notices maybe symptoms in themselves or symptoms in a loved one, if you wanted to point out anything from that point forward.
Well, so the first thing is we're going to treat it like any other stroke that comes in.
Mm-hmm.
So someone comes in, worst headache of their life. Maybe they have numbness on one side of their face, neck stiffness, like vague. And sometimes it can be very vague symptoms. But I will point out, if you have a family member that has a sudden severe headache, they definitely need to get checked out. If it's a sudden onset of a headache, especially even that sign of like a pop, they need to come into the ER and be checked out. So the first thing we're going to do is we're going to do a CAT scan. And most patients, when they come in, you're already going to meet myself or one of my colleagues in the ER, because we actually respond to all of the code strokes that come in through the ER or anywhere in the hospital. So we're there from the moment that you come in, basically to assess you and to make sure all the imaging is done appropriately. So we'll do a CAT scan, see if we see any bleeding on a CAT scan. Now, there are times that we actually don't see bleeding on the CAT scan. And the reason for that is that as time passes, really within like the first 12 hours of having that severe headache, high likelihood we're going to see some bleeding on a CAT scan, which is about 96 to 100% sensitive for seeing the bleeding. There are times when we actually can't see it on a CAT scan, and some people would think, oh, well, you can just do an MRI, but the MRI is not as sensitive as well. So in those cases, we will actually do what's called a lumbar puncture if it's been a significant amount of time since the headache started. I know it sounds crazy, but some people will come in, maybe they've had their headache for 3 days. At that point, it's only an 80% chance I'm going to see it on a CAT scan, or even a week out. And then I'm only like 50% chance I may see it. So at that point, we'll do what's called a lumbar puncture. So we'll numb up your back, they'll stick a needle into that space and get some cerebral spinal fluid. And we'll analyze that in the lab. And what we're looking for is they'll do a cell count. And so what we're looking for is how many red blood cells are in that first tube of fluid. We'll take 4 tubes, about 15 cc's. And the number of red blood cells in a healthy individual with no bleeding should really minimize to at least decreasing to almost 0 in that 4th tube. If the number is increasing, then we know that there's blood within that space from a hemorrhage, likely aneurysm rupture. They'll also send it to the lab. It takes about 12 hours for your blood to turn into this, which is called xanthochromia, or not your blood, your CSF. They'll send your fluid to the lab and put it through a centrifuge. And if it turns yellow because of the red blood cells breaking down, that's called xanthochromia. That's like a 99% sensitivity as far as like we know you've had a bleed.
Gotcha.
We will also, in the midst of all this, you'll already have had a CT angio of the head and the neck. And so that's a different CAT scan that actually looks at all the vessels in your head and your neck. So we can assess for an aneurysm as well. Unfortunately, if you have a ruptured aneurysm, you have won yourself a 14-day stay in the neuro ICU. And I know it sounds terrible, and I don't want people to not come in if they have this headache. The reason for that is that this type of bleeding is extremely irritating to the brain, and you are at high risk for something called vasospasm. And what happens is usually it can last up to 21 days, but we'll only keep you there for 14 if you look good. But, what happens is that it's so irritating to the vessels, the bleeding, that you can have vasospasm where the vessels kind of clamp down like this. And when they clamp down, you can actually have a stroke. So we go from bleeding on the brain to possible an ischemic stroke where you've lost blood supply because of the aneurysm rupture and the subsequent vasospasms. So it's very important that you're monitored, because we can do things to intervene to keep that from happening and prevent you from having a stroke. So some of the things that we do initially when you come in, we're really going to control your blood pressure to the guidelines. Neurocritical Care Society would be less than 160 for that top number on your blood pressure when you first come in. But once we've secured the aneurysm, we're actually going to let your blood pressure go extremely high because your body is protecting itself. So family members will come in and be like, oh, the blood pressure is like 180 or 200 systolic. And you know what? I'm okay with that because your body is protecting itself. It's increasing that pressure because the vessels are clamped down like this. So it seems crazy, but those are some of the things we do in the ICU. We also want to keep you very hydrated. You don't feel good, you have a headache, so you're going to get tons of fluids to make sure that you're hydrated. Make sure your blood levels are good. There's a medication that we give you called nimodipine that is been proven to decrease your risk of neuroischemia related to vasospasm, so essentially reduce risk of having a stroke with the vasospasm. And another thing that's that can happen with subarachnoid hemorrhages is you can develop what's called hydrocephalus. So that is when you have the bleeding on the brain, the blood has to settle, and it can settle in your spinal fluid spaces in the brain, in your ventricles. When that happens, they get really enlarged, and patients get fatigued. Their pressures can go up in their brains, and sometimes we actually have to put a drain in, called an external ventricular drain, to relieve the pressure and monitor the pressure in your brain. So we'll actually drain that fluid. So a lot of things go on while we're in the intensive care unit. It's why it's so important that you come into the hospital, because we've shown that we can significantly decrease your mortality or death rates by coming into the hospital and being treated appropriately.
Yeah, no, absolutely. So just reiteration of that, coming in as soon as you can. That's definitely a theme that as talking through, through our stroke awareness series for sure. And could you tell us, Kristie, just a little bit about the team? Because I know that when patients come in, right, they have a set of individuals like yourself, and then a few others that are part of that team for the patient care, right?
Yeah. So at our facility, so we are considered a tertiary. Did I hit something?
Oh, we can't see you. Can you turn your camera back on?
Oh, I'm not really sure how
There
to
you
do
are. That's okay.
So we at Baptist are a tertiary comprehensive stroke center. So we, have really all the tools that you need to be taken care of effectively. So from the moment you come into the ER, they'll activate a code stroke. So you're going to have a vascular neurologist that's looking at you, as well as a nurse practitioner from the neurointensive care unit to assist them. And we all communicate in real time. So we have the ER physician, you have the stroke neurologist, and then we have our endovascular neurosurgeons and our critical care physicians, the critical care physicians in the ICU. So you have a whole team that is already evaluating from the moment you come in through the door, whether it be a subarachnoid hemorrhage, an ischemic stroke, or even a bleeding on the brain. I mean, just a regular hemorrhagic stroke. So we really take a team approach, and we do kind of have a closed model ICU. So once you come up to our intensive care unit, the nurse practitioner, myself, who sees you downstairs, I'm going to be the one taking care of you in the ICU as well. So I know what happened to you up until that point. And continuity of care is really important to us. So, I would continue seeing you, like say I worked 3 days in a row, I would likely take care of you all 3 of those days. And we really focus on signing out to one another, knowing, hey, this is what the patient looked like when they came in, this is what they look like now, because it can be the subtlest change that is so important for the patients. And I know people get so tired of us asking the same questions over and over again, but it can be the slightest thing is, you know what, their arms, I don't know if you can see my hands in the camera, there we go, like their arms were like this and now they keep doing this. Like, you know what, that tells me you have some weakness in this arm that you weren't aware of. So, yeah, very team-based approach at our facility.
Yeah, that's wonderful. And like you said, super important for even just those small changes that could happen. Looks like we have another question from Robert. He's curious and asks, is taking aspirin a good or bad thing?
So a baby dose of aspirin is a pretty it's a pretty standard treatment, I guess, for heart health and even like stroke prevention, just a baby aspirin. All of that's going to depend on your background, right? If you have, GI issues, you might have, if you have a history of like a bleeding ulcer or something in your stomach and your gastroenterologist doesn't want you to take NSAID, which is an aspirin, then you probably shouldn't take it. But it's a good prevention. I'm not going to recommend it blankly for everybody. It's going to depend on really what kind of medical issues that you have. But for cardiovascular health and stroke prevention, it is something that we recommend in those patient populations.
Okay, great. Yeah, thank you for answering that question. So Kristie, as our conversation comes to a close, is there anything that you'd like to leave our viewers with just the biggest one or two takeaways about aneurysms and our discussion about what to expect when you come to the hospital?
Yeah, so I think the biggest thing is that if you know that you have a family history of it, then you need to probably at least be screened for an aneurysm. Talk to your primary care provider. You can reach out to Lyerly Neurosurgery, who I work for, and get that initial screening, because that's something that we can prevent. Obviously, heart health, brain health is all important. Really modify those risk factors if you can. Quit smoking, limit your alcohol intake, control your blood pressure, control your diabetes. I can't stress it enough. It's going to be better for your entire body. A subarachnoid hemorrhage and aneurysm rupture is a rupture is a medical emergency. So you need to be seen right away. I didn't say this yet. I did kind of save it for the end, but 12% of people with a subarachnoid hemorrhage do not survive to make it to the hospital. That's how serious it is. So, wow. It's important that we don't take it lightly and we treat it, appropriately. That being said, although your overall mortality rate, so your death rate, is around 35% of having one, that includes people that didn't make it to the hospital. At a tertiary center like Baptist, it's a comprehensive stroke center, your mortality and death rate goes down to around probably like less than 20%. So it is important that you are treated and that you are treated appropriately in the most appropriate facility. So I can't really stress that enough.
Yeah, no, definitely some great takeaways. And Kristie, I just want to thank you so much for your time today. I really enjoyed chatting with you on this and really learned a lot just from today and throughout the 3 weeks that we've had for our Stroke Awareness Month. And for our viewers that are tuning in, if you weren't able to catch our presentations before, they are available on our Baptist Health Jacksonville page, as well as this one. You'll be able to record back, so if you missed or watch back, you'll be able to see our whole conversation. But I want to thank you all so much for tuning in, and of course, if you're interested in seeing more of our expert sessions, just visit the link above us, and you'll be able to get in the know of when we have our next expert on. But Kristie, thank you so much for your time, and our viewers for tuning in. I hope everybody enjoys their day.
Thank you so much for having me.
Absolutely. Bye, everyone.